We are live.
Good evening. Welcome to lecture 54 of iFocus. Today we have Dr. Shreyas Ramamurthy sir, who will be taking on cornea flashcards, which will be a very quick revision of all the cornea module which we had during the previous sessions. So we already know him. He has already been here on this platform. So he's currently working with I Foundation Coimbatore. We are very happy to have you again, sir. Welcome and
Thank
over.
you. Thank you so much, Rika. I'm here once again to bore all of you, but this time hopefully we'll have a more interactive session rather than just a lecture. So by design, this is cornea flashcards, and they're supposed to. It's like a OSCE platform. So I'll have a picture, simple spot diagnosis, and we'll discuss a couple of points with each. If the PGs on the hot seat can, if they can kindly unmute and also show the video, it'll be nice. We can have a more interactive session.
Dr. Soni and Dr. Ajiba, you can unmute and switch on your video. Few other participants will be joining in soon.
Sure. As and when they come in, they can also do the same. So we can have some discussion. Otherwise, because the slides I've got on are all just different case scenarios. So we can just, all of them are almost like a spot diagnosis.
Dr. Soni, Dr. Ajiba, you're there, right?
Yes, ma'am.
Okay, perfect.
Would
you
you
can switch on your video?
You can switch on your video. Great, wonderful. So let's start off.
Yeah.
So I'll just start sharing my screen. And so, Dr. Ajiba, where are you from?
Hello, sir, can you hear me?
Yeah, I can hear you.
I'm from Chennai.
Wonderful. And
I'm from Chennai doing diploma in Shankar Netral.
Excellent. And who is the other postgraduate?
Dr. Soni is there.
Dr. Soni. Okay. And Dr. Soni, can you hear us?
Maybe there's some connection problem, so
Okay. Great. So, Ajiba, would you like to just start off and say
Yes,
what do you think this ulcer is, and is this what do you think is the diagnosis?
So, with the history, the probable diagnosis would be a fungal corneal ulcer, sir.
Great. So what are the characteristics? What do you think what would typically, is this picture which you're seeing a typical fungal ulcer? Is there anything atypical about it?
So it has a feathery margins.
Yes.
That is a typical feature.
Right. So this kind of dry looking surface, where there's no specific luster, you don't see too much of sloughing, not as much necrosis as you would see in a bacterial ulcer. It's a dry looking ulcer, and as you clearly said, feathery margins, those typical of a fungal ulcer. So fungal ulcer is a great mimicker also. It can almost present in any way, though the pictures which I put up are classical of a fungal ulcer, but they can have a separative picture as well. And that is why it becomes extremely important that you scrape almost every ulcer and not start them off on empirical treatment. Can you name two drugs which are used against fungal ulcer? What are the two commonly used drugs against fungal ulcer?
So, amphotericin.
Okay. That is, though it's a good drug, that's one of the least commonly used ulcers as far as our initial topical management is concerned. So, what are the two common fungal organisms that we normally come across? Sorry, Ajiba, since you're the only postgraduate, it's not fair that I keep questioning you. But anyway, so Fusarium and Aspergillus are usually the most common diagnosis that you want to look for. And the two common drugs that we use is natamycin, which is 5% natamycin, which is a suspension, And then you have voriconazole, 1% voriconazole, which we use. And typically, natamycin is more effective against Fusarium, and voriconazole is more useful against Aspergillus. So the two commonly used drugs with the two most common fungal organisms that we see. Amphotericin B is usually, because it's very toxic and is usually reserved if we are not getting an adequate response to these two primary agents, or if we are seeing primarily a candidal infection, candida. But again, candida fungal keratitis in our part of the country is not, or rather in our country as a whole, is quite uncommon. Though in Western literature, they do see more candida than Fusarium or Aspergillus. Okay, so we'll move on to the next this thing. So again, another diagnosis which is written in this itself a beautiful picture. So what is the diagnosis? No trauma, just foreign body sensation, redness, photophobia, and pain.
It's a
herpetic dendrite.
with the pattern of staining, it could be an herpetic ulcer.
Wonderful, wonderful. So because it's a dendritic ulcer, right? So is there is only what causes a dendritic ulcer?
Yes.
Maybe anyway.
Sir?
Just a general thought, Dr. Olika and Dr.
Yes, sir.
If Dr. Ajiba is going to be the only PG, should I just go on and take it like a quick lecture and finish it off? Because there's no point in constantly asking her questions alone.
Yes, I'm sure she doesn't mind it and she would like it also. And if
you would like
you
it
want,
also? You're answering on her
me and
behalf.
Harika also.
Yeah, if you want to answer this, we can just then carry on.
No, that's fine. Right. So Ajiba, feel free to chime in with your answers whenever you know them. And
Yes, sir.
so essentially, so what we'll do is we'll take through each clinical picture. I'll just present a few important points about each picture, what we should not miss and what we should look out for. Okay. So this is a typical dendritic ulcer. When we say dendritic ulcer, we are generally looking at either a HSV or the herpetic zoster. But there are lot of other infections and other non-infectious causes which can present like a dendrite, which we call a pseudodendrite, and that's what you need to differentiate from. So pseudodendrites could be just a healing epithelial defect. You could have acanthamoeba infections. You could even have fungal infections, but most commonly a healing epithelial defect which causes this. Even drug toxicity. Occasionally, you could even, a cornea verticillata you could mistake it for a dendritic ulcer. So you need to look for these rule out pseudodendrites. And one of the common ways you do it is by staining. So generally, the dendritic ulcer has this typical staining that you see with this branching pattern and the terminal budding that you see here so beautifully in this picture. And those terminal buds are very classical of a HSV dendrite. And occasionally, you could also use a rose bengal and do what we call a double staining, where the fluorescein stains the base and the rose bengal stains the edges. So essentially, a de-epithelialized area is stained by the fluorescein, but the devitalized cells are stained by rose bengal. Okay. Any guesses on this picture? Positive family history, adolescent age group, very gradual reduction in vision.
Dr. Soni, you would like to take that? So Dr. Soni is back online.
Wonderful.
There was some problem with her internet.
Sure. Great.
Good evening, sir.
Yes,
Sir,
good
this
evening.
looks like corneal dystrophy, sir.
Wonderful. Would you like to guess what kind of dystrophy this is?
Congenital hereditary endothelial dystrophy, sir.
So congenital hereditary endothelial dystrophy presents at birth or at very, very young age, and is actually almost a differential diagnosis for congenital glaucoma. So that is a diffuse edema because of endothelial dysfunction where the corneal pachymetry is very, very high. Here you're seeing stromal opacities, right? So this is in the stroma.
Okay.
So it's a macular dystrophy, sir?
Right. Wonderful. So this is what reason I put up this picture of macular dystrophy is because very often what we are told is that macular dystrophy is diffuse opacities, intervening area is hazy, there is not clear, unlike in granular dystrophy. It involves the full thickness of the cornea and can involve from center to periphery. But all this what I'm talking about is a more advanced presentation, which you normally see a little later in life, 4th or 5th decade. But in the early age group, that is between, let's say, 10 and 20 or around 20, this adolescent age group, you see that this is an early presentation of macular dystrophy. And this will progressively increase over the next couple of decades. Okay. So yes, you do see that there can be in the early stages, the intervening area may not have become as hazy. But in this picture, you see it is slowly becoming hazy in the other eye. But these opacities are very, very classical of macular dystrophy. Okay. What about this condition? What do you think is the diagnosis? Patient with recurrent episodes of redness, irritation, and has, in this case, at least no history of contact lens use. So what do you think is the diagnosis? What is the association?
Marginal keratitis, sir.
Excellent, marginal keratitis. So why do you say this is marginal keratitis? What is typical of marginal keratitis?
Sir, it is associated with blepharitis, other lid condition.
Right. So essentially, it can be, yes, like you mentioned, lid conditions like meibomian gland dysfunction and blepharitis could be associated with it. Basically, it is supposed to be a toxic reaction to a staphylococcal infection, though it's not a direct infection. It is more of an immune reaction. So the reason why we call it an immune reaction, because it's a sterile infiltrate. You see an intervening clear area usually, at least in the early stages, in the epithelium is intact. It's an infiltrate with an epithelium which is intact, but of course, if left untreated, the epithelium can break down. Most often, it is focal in presentation, but it can be multifocal also. If it is multifocal, we need to rule out immune compromise, and also it could be a contact lens wearer who could also have this picture. And the other thing is, which we need to rule out, is rosacea keratitis. So acne rosacea, very often we may miss out these, because at that time when the patient is coming to us, we may not see active acne on their face, but very often they may have acne, and along with it is associated ocular rosacea, where you see meibomian gland dysfunction, lid margin telangiectasias, and you also see very often these marginal keratitis as well. Okay. You please feel free to stop me if you have any doubts, any questions. This is a picture of a pentacam, and I will not bore you all with the Scheimpflug principle, and I'm sure you all had a good pentacam class, and we'll move on to the next slide. Yeah. So what about this? What is this condition? So it's a young
Keratoglobus, sir. But no, it's acute hydrops.
Wonderful. Excellent. Excellent. So this is a young individual with sudden onset pain, photophobia, and drop in vision. So like you mentioned, it is an acute hydrops. So why do you say it's an acute hydrops?
So there is a split in the decimat, sir.
Correct. That is the cause. That is the cause. Excellent. But is there, I mean, a split in the decimus? Yes, occasionally, if we are lucky with different scans and different axes of ASOCT, we should be able to make it out. We could make it out in certain conditions. But very often we may not be able to find out where exactly the split is. But what else tells you that this is an acute hydrops? So you see these typical fluid clefts, both on slit lamp microscopy as well as on ASOCT. And these fluid clefts are very, very classical of hydrops. No other cause of decompensated cornea will have as many fluid clefts as you see in hydrops, because of this acute increase in fluid ingress into the cornea, you see these accumulation of these fluid clefts. Okay, so how do we manage acute hydrops? Any options? Would you like to do nothing? Would you like to do something called a desmetopexy? Would you like to use air for desmetopexy, or would you like to use something like C3F8 for desmetopexy? So essentially what we are trying to do in hydrops is we are trying to oppose the descemes membrane back to its original position, so that the split which has occurred now through which the fluid is now entered into the cornea, we want the descemes to be restored, and the pumping action of the descemes to gradually remove the fluid which is there in the cornea. So for that purpose, we do desmetopexy. However, often it is not successful. Main reason is when the descemes ruptures, because of its elastic nature, it tends to go into a scroll, and that we cannot unfurl by just doing a desmetopexy. So it's only over a gradual period of time that polymegathism, the gradual the endothelial cells spread out into the bare posterior stroma, and then they pump out the fluid, and then you have a resultant scar. So no treatment will also possibly end up with the same result. The only reason for doing a desmetopexy is as opposed to just observing a patient and treating them conservatively with lubricants and like something like hypersol hyperosmotic agents. The only reason is that you can try and give a slightly faster recovery. The usually anywhere between 3 to 4 months would be the natural history of this disease, and you can reduce that time by doing a desmetopexy either with air or with C3F8. Ideally, if you're doing with C3F8, we need to do an inferior PI, because usually these are young patients, phakic eyes, and you could develop a pupillary block, and therefore an inferior PI is a must when we do C3F8. And normally we use a non-expansile or concentration, because if you have an expansile concentration injected, that will definitely lead to a increase in IOP. And the other thing is, when you have a chronic edema, you could have peripheral deep vessels which come in. So the main reason the cornea is compact, does not develop vessels and is normally avascular, is because of its compact nature. And when the compact nature of the cornea is lost, when it becomes edematous, these vessels can grow in. Then when you have deep vessels, this can result in vascularization, and this mainly reduces the prognosis of a subsequent graft. Even if you are able to do a DALK, it can lead to interface vascularization. If you do a PK, it can lead to increased chances of rejection. So for that reason, if the edema is extending right up to the periphery, then in those cases, you would probably do well to at least attempt a desmetopexy and reduce the chances of new vessels coming into the cornea.
So here, can I ask a question?
Yeah, please.
Yeah. So for these cases, what is the time which we have to, rightly intervene? So beyond which time interval, if we intervene, there is not much benefit to the patient, or that?
Unfortunately, we don't have a perfect answer to that question, in the sense, like I said, we don't even know for sure. Even if let's say the patient has come to you on day 1 or day 2, you can never say with 100% surety that this patient will benefit from a desmetopexy. Because like I said, when the descemes rips, depending on the size of the rip and the extent of the rip, if it's a small rip where the edges are not rolled on itself, then a desmetopexy works very well, and you'll see a very quick reduction in edema. But if it is a larger hydrops, larger split, and the descemes is rolled on in itself, then actually a desmetopexy itself does not work extremely well. Having said that, generally these are acute conditions, and patients would present to you at an early stage. And if the edema is extending towards the periphery, you would do well to do a desmetopexy. If it is a central small hydrops, very often they resolve spontaneously on their own without any need for management. Because when it's a central edema, the risk of deep vessels is much, much less. Yes, the time to resolution we can cut down, but more importantly is to reduce the risk of neovascularization in the cornea.
Thank you, sir.
Thank you. So I'll skip past pterygium. I mean, I think it's too basic. Okay. So Dr. Soni, would you like to answer what this is? What do you think this condition is? It's like we have one more postgraduate who's joined us. So,
sir, peripheral corneal ulcer.
right.
It is. It could be Mooren's or PUK, like something like that.
Right, right. So is Mooren's a PUK or is PUK a Mooren's? Mooren's is a type of PUK?
Mooren's is a type.
Type of PUK. No? Yes. Please say yes. So Mooren's is a type of PUK.
Yes.
So Mooren's is actually though we are quick to jump to a diagnosis of Mooren's ulcer, and in this case you're right. You're absolutely right. This is a Mooren's ulcer. But Mooren's ulcer is actually a diagnosis of exclusion. But of course, we have certain criteria by which you can clinically diagnose a Mooren's ulcer. So what are those criteria called? Have you heard of the name Watson's criteria? Right. So there are certain typical features of a Mooren's ulcer. So you have an advancing edge, which is in the periphery, and its spread is circumferential. Okay. And only after it is circumferential, it then goes to the center. Otherwise, the spread is first circumferential. And typically, you have these overhanging edges, which are infiltrated. Okay. And that is very, very typical of a Mooren's ulcer. You see this excavation underneath, and then you have an overhanging edge. And most importantly is the absence of scleritis. If you see scleritis, you're not dealing with Mooren's ulcer. You have to start investigating the patient systemically, rule out all the other autoimmune conditions, connective tissue disorders like Wegener's and SLE and all those diseases, because the scleritis is not present with Mooren's. So in this patient, you can see that the sclera is absolutely normal, though I'm sorry, I've not put a diffuse photograph here, but this is a typical Mooren's ulcer. And like I said, it's a clinical diagnosis and a diagnosis of exclusion. But an autoimmune workup is more often indicated when you are looking at scleritis. So how do you manage Mooren's ulcer?
Sohini and Ajiba, one of you can take the question.
Yeah.
Sir, shall I try?
Yeah, please go ahead.
Sir, we can either go with medical management or surgical management. Medically, initially we start with topical steroids if there is no perforation, and in surgical management we can do a resection, conjunctival resection with trimming of the edges.
Wonderful. Why does it help? How does it help? And how do you do the conjunctival resection?
Sir, actually, it is believed that when we resect, then some inflammatory mediators and all those things can be removed when we are doing a resection. So,
it's believed, like you said, very nicely, you use the word believed, which is correct. It is believed that many of the inflammatory mediators which come through the conjunctival vessels could be contributing to this, and therefore a conjunctival resection, that is where you see the ulcer 1 to 2 clock hours away from either side, and then a 4 millimeter margin you would leave behind, and you resect the entire conjunctiva around in that region, and that helps in reducing the amount of inflammatory mediators. So conjunctival resection. In terms of management, medical management is the mainstay actually, more than surgery. So initially we have a stepladder classification. So Mooren's ulcer itself has a benign form and a malignant form. So benign form you see in elderly, malignant form you see in a younger age group. Benign form is usually unilateral. You see the involvement is only about 3 to 6 clock hours or less than that. Whereas in the malignant form, the number of clock hours of involvement is more. It is more bilateral and in a younger age group. So depending on the extent of involvement, if it is a unilateral old age, less than 3 to 6 clock hours, you could do well with just topical steroids and conjunctival resection. That should be sufficient. But if it is more extensive, we step up to oral steroid, then we step up to immunosuppression. And if it is acute and spreading, you would also have to give an IV methylprednisolone. If you have a bilateral young patient, aggressive presentation, more than 6 to 9 clock hours, then you need to start the patient on IVMP concomitantly with IV cyclophosphamide, control the acute condition, and then keep them on oral immunosuppression. Okay. And then, of course, apart from conjunctival resection, in the surgical management are tectonic grafts. If there is a perforation or extreme thinning, you could do tectonic lamellar grafts or full thickness grafts, which are usually, depending on the shape, you could do a banana graft, which is what is most common, or you could even call it a donut graft if you're really going all over the 360 degrees. But essentially, it is required mainly for tectonic purposes and not for visual rehabilitation. Okay, this condition, it's a eye which has chronic inflammation. Patient is presenting to you with foreign body sensation. What do you think this is?
Sir, spheroidal degeneration.
So that's why I gave the history of chronic inflammation, even though this picture itself does not look like spheroidal degeneration. Picture itself is classical or something else.
Band-shaped keratopathy.
Correct, exactly. This is a band-shaped keratopathy. Okay. So when does band-shaped keratopathy happen?
Chronic inflammation is one of the things.
Correct. So chronic inflammation is one of the causes. Patients with long-standing uveitis, very commonly we see it in JIA, and patients with silicone oil-filled eyes, patients with hypercalcemia can also present with, or increased phosphorus can also present with this kind of band-shaped keratopathy. Okay.
So what is the reason for band-shaped in silicone oil, sir?
Just again, chronically inflamed eye. That is basically the. It's essentially the nutrition to the surface is altered, and in all these chronically inflamed eyes, unhealthy surface, there is a chronic inflammation which is taking place, and then subsequent calcium deposition, which is what causes the band-shaped keratopathy. Treatment is again superficial keratectomy, and then EDTA chelation helps in band-shaped keratopathy. What is this presentation?
So just a minute, can you please elaborate on the management of band-shaped keratopathy?
Yeah, so band-shaped keratopathy itself, say essentially, it's a fairly a palliative treatment, because most of the eyes with BSK don't really have great vision, but whatever little vision they have, there is a drop in their quality of vision, because especially when it comes into the visual axis. So essentially, you may have just a simple, what we call a Swiss cheese pattern, or sometimes you may have a slightly thicker plaques, and you can combine them with just first a debridement, a superficial keratectomy, and then do EDTA chelation to kind of remove the calcium. So you soak the sponge with sodium EDTA or potassium EDTA, and then you can keep it on the cornea, and you'll slowly see that the corneal clarity is improving on table as you keep applying it. And then you debride whatever is coming off with the chelation. And if sometimes these patients, we have to watch out because the surface itself is a little unhealthy. The epithelialization may not happen very quickly. So at least a bandage contact lens, or you could even combine it with an amniotic membrane graft to ensure that the patient does not end up with a persistent epithelial defect. So we should not do a procedure which is actually further going to endanger or end up losing whatever little vision they already have in these chronically inflamed eyes or silicone oil filled eyes. So a PED is something you need to watch out for, and that is why you need to be very careful before and really see if the patient is going to benefit from the procedure before you go ahead and do a superficial keratectomy with EDTA, with chelation.
So for usually, for what is the time we wait for the chelation to occur on table after putting EDTA?
So it's you can keep applying it and keep seeing. So usually within the first 5 to 10 minutes itself, the maximum chelation would have happened. And beyond that, whatever those deeper deposits don't really come off with the chelation. Otherwise, a more aggressive ALK and other procedures have been done, but usually, like I said, because the visual prognosis is not so great, we try to avoid a graft in most of these situations. But fortunately, in this, most of the deposits are usually superficial and come off with chelation. You may have a mild underlying scarring, which is not uncommon, and that's acceptable.
Okay.
Yeah. And this condition, any guesses on what this is? Quickly growing lesion.
OSSN.
OSSN,
Wonderful. OSSN.
and there are feeder vessels which we can see, sir.
Excellent. There are feeder vessels that you can see. And what is this typical lesion? This morphology, what would you call it?
Keratin.
So typically in the cornea or at the limbus over the conjunctiva, you would either see a leukoplakic lesion like this or a papilliform lesion.
Okay.
And this typical appearance is that of a leukoplakic lesion. And what are the chemotherapeutic agents which are available? What are the modes of management that you have? Surgical,
Sir, interferon.
Great. Interferon. Then what else?
And topical mitomycin C has also
Mitomycin C has also been used. So these are the two commonly used agents. So these chemotherapeutic agents can be used in different patterns. I'm sure there are oculoplasty fellows with us who also know a lot about it. So we can use them typically either for chemo reduction, especially when we are not able to get a clear margin. In this case, of course, you can easily get a clear margin, and it is very, very amenable for a surgical excision. But wherever you're not able to get a clear margin, you could do a chemo reduction and then take it up for surgical excision. Or you could do post-surgery if your margins are positive. You could do a chemo prophylaxis. That is also where we use interferon very, very commonly nowadays. In comparison to mitomycin C, which was what we were using more commonly earlier, it is less toxic. Patients are definitely tolerate it much better. And that has become the agent of choice in the management of OSSN now. Okay.
So can I add a point here?
Yeah, please go ahead, Harika. There's so much to add on OSSN. Yeah, please add it.
No, because you have just mentioned about it. One more method is intralesional interferon also.
Absolutely.
For bigger lesions, we can also give intralesional interferon that is usually given in 3 milli international units. Drops will be 1 and this will be 3. And we can just observe for the response for after 6 weeks, and then we can take a call on the excision or should we continue with the further injections.
Correct. Especially when it involves the lid, dorsal conjunctiva, and intralesional is actually something which comes to our is a savior, because really surgical excision is extremely difficult. Yes. When it is on the conjunctiva, on the bulbar surface, we still have surgical options which are effective. But however, intralesional is a very, very good modality where with repeated cycles, it could completely go away also, or at least you are able to bring it to a stage where you are now it's amenable for surgical excision. So, and very often when it is extensive, we have even done cases where the larger area of the limbus. I'm talking from purely a cornea point of view, so I'm not really thinking of the lids and other things. But let's say if it is a extensive bulbar lesion involving a very extensive area of the limbus, along with the excision, we can also combine it with a limbal epithelial transplant. This also works well, especially now that we have interferon and other chemoprophylactic agents available, which really have reduced the recurrence of OSSN. We've now, even on a primary setting, been able to combine it with limbal epithelial transplants, because a significant portion of the limbus does get damaged when there is extensive OSSN. Not in such a small OSSN, I would do nothing other than a simple excision, but when there is extensive, more than 270 or 300 degrees of involvement, patients also have and a concomitant LSCD which develops subsequently after the surgery, and you could even combine it with the SLED, and the outcomes are very, very satisfying. Okay, so what is this surgical procedure?
Penetrating keratoplasty has been done.
Right. So why do you say penetrating? Yeah, does it? Are you sure this is a penetrating keratoplasty?
Sir, sutures are there.
Sutures are there, of course, I agree. But suture, the only reason why you would say penetrating, lamellar also we put sutures. So endothelial keratoplasty like DSEC and DMAC, we don't put sutures, I agree. But you could this be a DALK, or does it have to be a PK? How would you differentiate deep anterior lamellar keratoplasty from a penetrating keratoplasty? Just, I mean, would you like to guess? So sometimes it can be
interface.
well, yeah, exactly. You would like to look at the interface, right? So how would the interface? What are you looking for in the interface?
Maybe in DALK, the bubble at.
Right. So DALK can be, like you said, either a big bubble DALK, where only the duas and decimes, or the predesmatic layer and the decimes are left behind, or it could be a manual DALK, where some amount of posterior residual stroma is also left behind. So whenever there is a little bit of posterior stroma left behind, you see a fine granular appearance of that posterior stroma which has been left behind, which is what we call the interface, which is visible. Or even in a big bubble DALK, especially in keratoconus patients, you could see very fine folds which are appearing in the periphery. Now, these are different from decimatic fold, DM folds, which you see. These, though they are also folds of the DM, but now the typical DM folds which you are talking about are because of edema, corneal edema. But in a DALK, let's say when we do it for an advanced keratoconus, now that is a decimus membrane which is on a cornea which might be in a keratometry in excess of 70 or 80 in a very steep cornea. Now you are going to replace it and put a flatter graft on top of it, and you're trying to bring it back to a keratometry in the 40s. So when you're doing that, there is a great redundancy of the decimus membrane. And when because of the redundancy of the decimus membrane, you see very fine folds in the decimus membrane which appear below the graft. And that is one more additional way where you can actually find out whether it is a DALK or a penetrating keratoplasty. Okay.
So here, can we take a question?
Yeah, please. Any
YouTube. What are the causes of Descemet rib?
Sorry?
What are the causes of Descemet rib?
Yeah, so I mean, Descemet's rib itself, we were talking about acute Hydrops, but of course, you have the typical trauma, you have delivery, then you have congenital glaucoma, where you have the typical Harb striae. So there are ways to differentiate them also, the horizontal, vertical orientations. So, but generally, these are more exam questions, not something which is a major clinical dilemma, because obviously because of the age group and other reasons, it's quite easy to diagnose why it has happened. And of course, you can have a DM rip because of iatrogenically after any surgery, any intraocular surgery like a cataract surgery also.
Okay, so as you mentioned about the acute hydrops, sir, one more question is any compression sutures helpful in acute hydrops?
Correct. I didn't cover that because we spoke about desmetopexy. Compression sutures has also been tried in combination with desmetopexy, where they believe the suture is going to kind of hold the decimes back with it. They all can be tried. The thing is, obviously, it's not done under direct visualization. These are full thickness sutures which are taken, which are believed to hold back the decimes. There are a couple of papers on it which have been published and have shown promising results. Now, unfortunately, we don't have enough head-to-head this thing saying plain desmetopexy versus desmetopexy with compression sutures, saying whether compression sutures are actually necessary or whether just a desmetopexy would have worked. Like you said, there's so much vagaries. Even in desmetopexy, we discussed whether it is going to be useful or not is very difficult to predict. So whether adding compression sutures is going to add value over a desmetopexy is arguable. But yes, that is another modality of treatment that you can mention in your examinations. That is observation, desmetopexy with accompanied with compression sutures can also be used. I hope I've answered that satisfactorily. We'll progress to the next one. Yeah. What is
intrastromal corneal ring segments?
right. Wonderful. So these are intracorneal ring segments, and I've put this photograph with a commonly associated complication. Not commonly, but if you have a complication, this is one of the most common complications.
Post-LASIK ectasia.
No, post-LASIK ectasia is an indication for intracorneal ring segment. I know post-LASIK ectasia is a complication of LASIK, but that's not a complication of intacs or intracorneal ring segment. So what is this that you're seeing here superiorly?
Extrusion.
Excellent.
Okay.
Extrusion. So one of the reasons is there are a couple of reasons. Most commonly, there is some vascularization which is happening there. Vascularization is either because of some chronic inflammation, or there might have been a loose suture there earlier which led to an epithelial defect. And this epithelial defect, already you must understand that very commonly the indication is keratoconus, and these patients may also have allergy associated with it. And when there is an epithelial defect, it attracts vessels, and these vessels can then grow into the interface like you are seeing here along the intracorneal ring segment. And because of the interface vessels and the ensuing epithelial defect and the unhealthy stroma, that leads to melting of the stroma there, and then the rings get exposed and then start extruding. Improper placement of the rings, inadequate depth of placement of the rings can also be predisposing factors apart from a loose suture, which could predispose to this complication. What is this complication? This is a post-LASIK patient. And what is this complication? Any guesses?
Oh, epithelial ingrowth.
Excellent. This is an epithelial ingrowth. So when you have a flap in the cornea or any interface, epithelium can grow into the interface, especially if there has been some associated trauma or some problem with the flap not adhering properly, or if it is a enhancement surgery has been done. A flap has been done primarily, but later we are doing an enhancement surgery after many years, and the flap does not heal properly. Then the epithelium, instead of growing over the surface, can go in, track into the interface and lead to epithelial ingrowth. So the problem associated with epithelial ingrowth is when they are very minimal. And let's say if it's just epithelial ingrowth can either be because of implantation. During your surgery, you have, because of your surgical manipulation, you've implanted some epithelial cells in the interface. So those will migrate, proliferate, but they have limited proliferative capacity and they will stop. So in those cases, you can just observe if it's in the periphery, not do anything, or you could do a YAG laser to the interface to create a region of scarring around it and prevent it from further spreading. But generally, those implantation cells, unless they are in the center, in the visual axis, does not require any treatment. But when it is communicating with the flap, and you stain this eye and you see any local areas of staining, that is an area which is now communicating, and that will keep on spreading. So in these cases, you may have to surgically intervene. First option would be, the problem with epithelial ingrowth, especially when it becomes this thick, is occasionally the nutrition to the surface of the flap can get affected, and therefore you may have recurrent defects over that region, epithelial defects, and even melting or necrosis of the flap in that region. So the management, and apart from that, you can also have astigmatism and irregular astigmatism caused by the epithelial ingrowth itself affecting your vision. So what we do is we lift the flap, we debride the epithelium, the ingrowth from the interface, from the bed as well as from the back of the flap. We apply something like a mitomycin C to prevent any residual cells from proliferating again. And then we also debride the epithelium from beyond the edge of the flap, so that as it heals, as the flap heals, and then the epithelium comes in. It gives you that enough time for the flap to settle down before the epithelium starts growing into the interface. So this is an initial management option. In very bad situations, if it's a flap which is not adhering properly, not settling properly, you may even have to amputate the flap. When you amputate the flap, you're getting rid of the flap altogether, and therefore the the risk is of there's no interface now, and therefore the epithelial growth cannot happen again. Okay. Right. So let's look at this condition. This is a very simple condition, and it's easy for you to tell. So this is after a cataract surgery. Sorry?
Pseudophakic bullous keratopathy, sir.
So, right, pseudophakic bullous keratopathy. Now, in the early postoperative period, if you have a picture like this, what could all be the differential diagnosis? Now, I've written 6 months back, so you said pseudophakic bullous keratopathy, perfectly acceptable answer. If it was
early early post-op, TAS?
TAS is one option, yes. So what would be accompanied with TAS? What else would you see in this picture? Where if this was early post-op, when the patient had a picture like this, what else would you see? So TAS is a acute inflammatory episode, right? Immediately post-op.
Yes.
So very often they are accompanied by extensive inflammation, pigment deposits on the endothelium. You could even have a hypopion, and that is typical of a toxic anterior segment syndrome. Otherwise, what other very common cause, what could it be? Here,
So DM detachment.
Yeah, DM detachment is another cause for edema. Yes, it could just be post-cataract surgery, striate keratopathy also, but
yes,
more than that, what is the main point which we are looking for here? So you're seeing a diffuse microcystic edema also here, right? So IOP is something which you need to rule out immediately before you jump in and say this is a pseudophakic bullous keratopathy, right? So you need to look for, especially in the early postoperative period, immediate acute rise of IOP, retained viscoelastics, increased inflammation. All of them can cause raised IOP. And even in a later stage, you need to rule out something like a neovascular glaucoma. Because the reason why it is important is because you may have a picture like this. If you are seeing any fine vessels on around the pupil, any NVI, which could easily be missed, the prognosis is greatly altered. So if you are a patient with this kind of clinical picture and has an NVI, your treatment becomes more palliative. You're not really going to do a DMEC or a DSEC in this patient and try and restore vision. So that is one very small thing which you need to look for before you immediately say pseudophakic bullous keratopathy, let's go ahead and do a endothelial keratoplasty. Okay. So this picture, especially the one on your right, is more classical. Elderly woman, a foreign body sensation, redness, photophobia, presence of symblepharon, a very dry looking lusterless surface,
Stephen Johnson
keratinization. 70-year-old woman, I've not said acute, chronically progressing. Have you heard of ocular cicatricial pemphigoid or mucous membrane pemphigoid?
Yes.
Yes, sir.
So before, because SJS, yes, is usually, the patient, it's very difficult or very rare that a patient forgets the initial acute episode of SJS. It is one of the most traumatic experiences a patient can have in their lifetime. And it is exceedingly rare that somebody would forget an acute episode of SJS. Yes, they may forget what drug, they may not know why it caused, or whether it was following an exanthematous illness, they may not remember. But when you see, especially in the elderly age group, a progressive keratinization, fornical shortening, symblepharon, dry eye, it's extremely important that we look for OCP OCP is very often a clinical diagnosis. Of course, you can do a biopsy, especially in the early stages, and that is also useful. And these patients, especially when they are progressive, which you may not see by just looking at the clinical picture, it's very difficult to tell whether this eye is progressing or not. So essentially, in serial photograph is very, very important. You take in all gazes and look for any increase in the symbolifera. And these patients usually require immunosuppression, systemic immunosuppression, and fairly strong systemic immunosuppression like cyclophosphamide, or if they are lucky, they would get away with an azathioprine as well. Okay, but OCP is a condition which you at least need to, even if you're not managing them, you need to, something you need to look for. When I talk about Schirmer strip, it's maybe, I'm just trying to look for what's the time. Okay, so we have, I think, 5 more minutes. So I'll just, so this is just a Whatman filter paper, Schirmer's test. So how do you do a Schirmer's test? Anybody?
Sir, we can do it in 2 methods, sir.
Right.
With local anesthetic and without local anesthetic, sir.
Right.
Schirmer 1 and Schirmer 2.
Excellent, excellent. And what are we seeing in both? What
So
are we
we'll
seeing?
put it.
Wetting of the paper, sir.
Right. No,
Normally,
what are you seeing in Schirmer 1? What are you seeing in Schirmer 2?
Schirmer 1, we will see basic
Basal.
Basal and reflex, right?
Reflex.
basal
Yes.
secretion
Right.
of the lacrimal gland.
And Schirmer 2, I mean, or rather with, let's not confuse with Schirmer 1 or 2. Let's say with or without a local anesthetic. So with local anesthetic, you're looking at the basal secretion, right?
Yes, sir.
Right. So would you do it with eyes open or eyes closed?
Eyes open, sir.
Can we do it with eyes closed as well?
Yes, sir.
Okay. So the reason I'm asking this question is essentially Schirmer's as an individual test is perhaps one of the most useless tests that we have in terms of diagnosing a dry eye, because it is so variable in its values and presentation. Yes, when you have a Schirmer's of 2 or 3, you could say that a patient has dry eye definitely, but it is very, very variable. The reason I'm asking all this is Schirmer, even if you're saying a patient has dry eye and you're starting to treat the patient and you want to do a follow-up, repeating the Schirmer in the same setting is important. For whatever little use it has, clinical use it has, we must repeat the Schirmers in the same setting. Primarily, the first time you've recorded a low Schirmers, you should see whether you put a local anesthetic, whether the patient was sitting with eyes open or eyes closed for duration, whether you did it for 3 minutes or 5 minutes, and whether the patient was, and it's also the room which is important, whether the patient was sitting directly under a fan or air conditioner. All these conditions have to be, it should be a repeatable condition. Do it with the same pattern so that you get a comparable reading. So that's the only clinical caveat in this slide. So quickly, what is this?
Herpes zoster.
Yeah, so because I've written skin lesions over the face, you
yes,
can say
sir.
herpes zoster. Otherwise, this could also be any form of endothelitis, right? So typically a viral endothelitis where you see these typical pigmented capes on the back, and as well as you see a ring of edema. What is this? I'm just rushing through because we have only 5 minutes, so I'll just quickly run through and
filamentous keratitis.
Yes, this is typically filamentary keratitis, and this can be a great cause for irritation and dryness. Yes, so, and can cause a lot of inflammation on the surface. Patient can be very, very uncomfortable. So this is actually more than a typical of a particular condition. Many causes of inflamed surface, dry eye can have filamentary keratitis, and that is usually indicative of a more severe form of dry eye. So we do remove these filamentary keratitis. We can remove the filaments and then treat them with some, reduce the amount of surface inflammation by adding topical steroids, give them lubricant, and occasionally N-acetylcysteine has also been found to be useful. That can also be used. skip past this. Also skip past. Yeah. Let's look at this quickly. What is this? So is the patient
Neurotrophic ulcer, sir.
excellent? Before we could even say anything, yes. So symptoms persisting for a longer duration. So why do you say neurotrophic ulcer? Is this does neurotrophy is one of the causes for this? I agree, but what is this essentially?
Punched out lesion.
Punched.
So what would you call it? What is this? Instead of directly going into neurotrophic ulcer,
Non-healing.
what is this essentially? Non-healing ulcer is right, but is there something else what you'd like to say?
Exposure keratitis.
No, exposure keratitis is a, it could be a cause, but what is this called? So this is a persistent epithelial defect,
Okay.
right?
Persistent,
So
okay.
that is how you would rather label it. And a persistent epithelial defect, because you see a very well-defined margin, unlike the regular epithelial defects that you see with ulcers, and you get a sloping edge. And the underlying area you see is very unhealthy. There is some infiltration, and it's because of this combination of possibly a neurotrophy could also be an underlying component, but it is a vicious cycle. So you have underlying unhealthy stroma, epithelium which is not able to heal properly, and then there's inflammation. The inflammation and unhealthy surface prevents the epithelium from growing, and because the epithelium is not growing, tears which contains the main inflammatory mediators are again exposed to the underlying surface and can cause subsequent further inflammation. And this recurrent cycle can cause increased inflammation, melt, and even a perforation. So management is to address the underlying inflammation, add lots of lubricants, put in a BCL, do a torsorrhaphy, and do an AMG, all in a staged manner or in combination can be used to resolve a persistent epithelial defect. Okay. I think we've run out of time. Is there any particular questions I would love to answer?
So you can go ahead and take a few more if you'd like.
More? Okay,
I think we
sure.
all are enjoying it.
Thanks for saying that. So we'll just go ahead. Yeah. So what is this device?
Sir,
Keratoprosthesis.
The keratoprosthesis. Right. Wonderful. Wonderful. You know a little bit more. Would you like to hazard? Is this the type 1 or is this a type 2?
It's a type 1
Type
keratoprosthesis.
Type 1 keratoprosthesis. Wonderful. Wonderful. Any idea why you would use the type 1 keratoprosthesis?
So the
If
cornea.
Yeah, please go ahead.
If the corneal surface is wet, you go ahead with the type 1 keratoprosthesis.
Excellent. Excellent. Who is this? Wonderful
Ajiba,
answer.
sir.
And where did you say you're studying, Shubha?
Shankar Netralaya.
Wonderful. Absolutely. I should have guessed that. Excellent. So it's so nice that you said wet and dry surface. So that's a very, very important point. And on a wet surface, you would do a type 1. In a dry surface, you would do either a type 2 or a OOKP or a modified type 1 keratoprosthesis like a LVP keratoprosthesis. But where do we use the keratoprosthesis? Let's say majority for a basic discussion, let's just go ahead with type 1 keratoprosthesis.
Sir, if there is a lot of corneal vascularization and we expect the repeated graft also to fail, in those cases, we can go for a keratoprosthesis.
Correct. So typically, we do it only in patients with bilateral corneal blindness, typically. And usually, like you said, where a graft may be a very high-risk graft because of extensive vascularization of the cornea, or a patient has limbal stem cell deficiency because of whatever be the reason, or if there is a multiple failed grafts, or patients with aniridia. All these are common indications where we would do a type 1 keratoprosthesis. Limbal stem cell deficiency, like chemical injuries and other reasons, are also the leading indications in our country for doing a type 1 keratoprosthesis. What is this ulcer?
Geographical.
Geographical.
Wonderful. So where do we get a geographic ulcer? Why do we
viral keratitis if it has been inappropriately treated with steroids?
Excellent. Very good. So inappropriately treated with steroids is a very common thing. What is this diagnosis?
So recurrent corneal erosion.
I'm not sure
Recurrent
how clear it is for you. my attempt here is to focus on the endothelium. And the picture is actually a high magnification picture of the endothelium, showing something on the endothelium. So these reflections which you're seeing on the epithelium are just of the tear film. So ignore that. What are we seeing here?
Gatti.
Correct. These are typically guttae. Okay. So, so that's why I said high magnification focused on the endothelium. We are looking at a specular reflex of the cornea where we are looking for guttae. Okay. So this is very, very important. Ideally, in all patients who come to you for even as simple as a cataract surgery, please do this examination. Look closely for guttae. One of the leading causes for pseudophilic bullous keratopathy, one of the leading causes is a
miss out
earlier
Fuchs.
Fuchs endothelial dystrophy, right? So it's important that you do this examination, look for guttae. And when would you do a combined surgery? When would you do only cataract surgery? Is that too much to ask?
Sir, if the endothelial cell count is less than 700 cells per millimeter square, we have to go for a combined.
What is the source? Why do you say 700? I'm not disagreeing with you, but if you were to say in an exam, because
500 to 700.
So in an exam, at least if you had to be a little more specific, the American Academy guidelines suggested that a pachymetry of greater than 640 or an endothelial count less than 1000, you would go in for a combined surgery. However, these are not set in stone, and of course, if the patient already has decompensation, like what is the earliest sign of decompensation that the patient talks about?
Early morning.
Right, early morning blurring. So that is one. That is so. If the patient has these signs, we can go ahead with a combined surgery with the endothelial keratoplasty and cataract surgery. Otherwise, just a stage 1 Fuchs where patient has no symptoms. Very often, a well done cataract surgery using appropriate viscoelastic agents like sodium hyaluronate would be could actually obviate the need for a endothelial keratoplasty, and the patients actually can have very good vision. But otherwise, you would do a DMEC or a DSEC combined with a cataract surgery. What is this condition? So you mentioned that in the previous slide.
Recurrent corneal erosions.
Recurrent corneal erosion.
So the reason I've put up this photograph is recurrent corneal erosion, unless the patient has a very significant epithelial basement membrane dystrophy, very often you will not even see anything. Patient complains of pain, irritation, will come to you saying morning on awakening, I had a lot of irritation, pain. But a few hours later, you'll find everything is normal. So that is very typical of recurrent epithelial erosion. But occasionally, you can have these kind of very cystic pearly appearances along the edges of the healing edges of the recurrent epithelial erosion. That is one sign. Then you may have negative staining as well, as you see in this picture. This negative staining and this are very typical of recurrent epithelial erosion. And what management options do we have?
Anterior stromal puncture could be done.
So anterior stromal puncture, when do you do anterior stromal puncture?
And
so
when it is not involving pupillary area.
Correct, exactly.
We do it to induce some scarring, like so that the attachment, reattachment can occur.
Very nice, very good, very good. Then what other option do we have?
Sir, initially we can try with lubrication.
Bandage, contact lens, lubrication, and hyperosmotic. So ideally, yes, you would like to approach in a stepwise manner. So you would say you would use, you would basically treat the patient conservatively, symptomatic treatment with lubricants, maybe a cycloplegic, and then put in a bandage contact lens and also give a hyperosmotic agent as well. And then subsequently, if the patient is having frequent episodes, recurrent episodes, then you would like to definitively manage the patient with either, like you said, anterior stromal punctures, which if they are in the periphery, if it is involving the center, you can either do a PTK, a phototherapeutic keratectomy, or even alcohol epithelectomy has also been spoken about and written, published about. But the way these things work is essentially there are a lot of interdigitations which grow into the epithelium, and that is what causes sloughing of the epithelium in the superficial layer. So we are trying to remove this epithelium and the interdigitations completely, give a smooth surface for the newer epithelium to migrate over, and that is how these treatment mechanisms work. Okay. Let's get the society. What is this diagnosis? Quickly.
Pellucid marginal dystrophy.
That crab claw.
Right. So a crab claw
Appearance.
appearance. Right. Wonderful. Sorry. Crab claw appearance. Right. And what is this diagnosis?
Giant papillae
Right.
could be a
Supi-
VKC, sir. Vernal Keratoconjunctivitis.
So VKC, what are the types of VKC?
Limbal.
So you have bulbar or palpebral or mixed. Okay. So what kind of complication is associated with each? What can bulbar cause? What can palpebral cause? What complication can you have?
Sir, chronic irritation.
Palpebral.
No, corneal.
Eye rubbing.
The palpebral
Yeah,
can
all
cause
those are symptoms of VKC. Yeah.
limbal stem cell damage is there with palpebral.
Sir, chronic rubbing can in future lead to keratoconus also.
Right. So you're right. You're right. All this chronic allergy irritation can lead to keratoconus. That's correct. That is a corneal complication. That's one. Then
Shields ulcers.
shield ulcer. So shield ulcer is again these kind of giant papillae because of the shield ulcer can be because of a mechanical theory or a cytotoxic theory. So mechanical is when these giant papillae are rubbing against the epithelium and causing recurrent breakdown, and the underlying surface gets inflamed, causing a shield ulcer. Or you could have a cytotoxic theory where you have the inflammatory mediators, which are, or a combination of both, where there is epithelial breakdown and then these inflammatory mediators are then causing the stroma to become inflamed. The other is this bulbar VKC. You see these
Limbal stem cell
can lead to bulbar VKC, can lead to limbal stem cell deficiency. Graft. Yeah, this is a very, very common thing which you see, but very often mismanaged and not treated properly, and that's why I put this up. So what are these?
Sir, adenoviral.
Yeah, adenoviral is the one of the most common causes, but what is the diagnosis?
SPKs.
Correct. So yeah, you could, so SEK or subepithelial keratitis or superficial keratitis. So essentially here the management is when you are treating a patient in the early phase, if they are not treated properly, they could end up with this, or a very severe form of adenoviral conjunctivitis could end up with this. So generally when we are looking at it in the early phase, when a patient presents to you, generally you are going to give them a lubricant or this thing. But if the patient has a very severe presentation, you end up giving a steroid. That is when you need to watch out for. Or if the patient has a very severe involvement, in the second week, please call back the patient. If they have this kind of picture, you would either have to put them on a low dose, a slow tapering of steroid, and add a cyclosporin or a tacrolimus as well. And this will have to be used for a longer period of time. Otherwise, the patient will keep on having very recurrent episodes. If you just give 1 week steroid, the patient will feel better, but they'll continuously have recurrent episodes. So managing them properly with a very slow tapering, if you have started steroids, a very slow tapering, but add on a cyclosporin and a tacrolimus after the second week of conjunctivitis, and maintain it over a long period of time to prevent recurrences of this condition.
So there is a question for your previous
please.
slide that in Fuchs endothelial dystrophy, if associated with cataract, what would you like to do? You would like to go for combined surgery or separate?
Yeah, that's what I was talking about. So all the criteria which we spoke about is only for combined surgery versus a separate cataract surgery alone. So originally, American Academy guidelines were speaking about these two conditions, like either symptoms of early decompensation, like early morning awakening if they have diminution of vision, pachymetry more than 640, endothelial count less than 1000, they recommended you do a combined surgery. However, like I said, these are not things which are written in stone. Very often we see that patients may have reduced counts, but even after a cataract surgery do continue to survive. So if there is decompensation is not present, you could do a good cataract surgery using agents protecting the endothelium, and very often they would do well for quite a long period of time. Because we must understand any form, of course, DMEC has extremely low rates of rejection, but has its own surgical complications. So before you subject a patient to any form of keratoplasty, we must see if they absolutely require it before we go ahead with a combined surgery in those cases. So last picture, quickly we'll go through this. So this is obviously a corneal tear which has been sutured, and some sutures have already been removed. It's extending from the limbus. So some things which I wanted to discuss here is when you have a linear tear, if it is in this here, it's in the periphery. If it's extending into the visual axis, one thing we must remember is, along with apposition, which is obviously our primary aim here, in terms of principles of suturing, you would generally put a slightly longer, first suture the limbus, ensure the limbal anatomy is maintained. The first suture, if it's traversing the limbus, the first suture goes along the limbus. And once the limbal anatomy is restored, then subsequently sutures are placed. In the periphery, you can have longer sutures which are more widely spaced. But as you come to the center, you generally want to have shorter sutures which are more closely spaced. This is one, to reduce the extent of scarring and the size of sutures in the visual axis, and also to reduce the amount of astigmatism that may be caused. So it's just a small caveat on principles of suturing that we want to give. So thank you so much. I'll stop sharing here. If there are any questions, I'll be happy to take them. We've already 15 minutes beyond time, I think.
No, sir, that's absolutely all right. We all enjoyed it, and we were absolutely attentive throughout the session.
Thank you, Rolika.
You've covered all the questions. In fact, you've covered the questions. We've asked you the questions on the social portals also. So that completes everything. So.
Thank you. Thank you so much. Thank you, SS sir, for joining. Really, it's a pleasure to see you each and every time. I can't but admire the kind of energy and focus that you have to be doing this day in and day out, and so many thousands of PGs across the country are benefiting so much from this, from your program. Kudos to you, sir. And you have a wonderful team along with you. They really are doing a great job. I think you're on mute, sir. Sorry, we couldn't hear you.
All right. I said I just sit around and they run it.
Absolutely, sir. They are running it flawlessly, no doubt about it.
Absolutely. Thank you so much.
Thank you, sir.
Good night.
Thank you. Thank you so much, sir.
Thank you, everyone. Thank you so much. Good night.
Thank you, sir.
Thank you, sir. Thank you, sir. Good night.